Welcome to Health-Edu platform. Today we are going to discuss the conservative treatment of idiopathic scoliosis. I'm by names of Dr. Pastel. I'm a prosthetist and orthotist working as a tutorial assistant at University of Rwanda College of Medicine and Health Sciences. The content of today, we are going to discuss first the introduction to scoliosis, the classification of scoliosis, where we will have neuromuscular, congenital sclerosis, and idiopathic scoliosis. And the third part, we'll see the types of sclerotic curvatures, the patient assessment, how do we assess the patient with scoliosis, and how do we treat the patient with idiopathic sclerosis, specifically on conservative treatment. And the last one will be the references. Let's start with the introduction to scoliosis. What is scoliosis? The sclerosis is a three-dimensional and structural abnormality consisting of spinal deformities in sagittal, frontal, and transverse plane. As you can see from this picture, this is a normal spine in frontal plane where it's straight, but when the patient is having scoliosis, it tends to have a sagittal curvature, frontal curvature, and transverse. All planes are affected. And this deformity is characterized with a lateral curvature of the spine, and it is always accompanied with some degrees of vertebral rotation. That's why it's a three-dimensional. And to be called a scoliosis, it has to have a lateral curvature with more than 10 degrees measured by the Cobb angle. We'll see later what is Cobb angle. From this picture, we want to see in the frontal plane where we see on this side, this is a concave side of the curvature, and on this side, it's a lateral convex side. As when the patient bends, most of the time in scoliosis, we have to see the hand. And what happens exactly on the lips and the vertebra itself? On the convex side, we see that the ribs are pushed laterally and anterior on the convex side, while on the convex side, we see that the ribs are pushed posterior and the thoracic cage are narrowed. And on the vertebra, we see that it has rotated towards the convex side. And the spinous process, when you feel from the patient, you see it has deviated to the concave side of the apical vertebra. And what's the prevalence of scoliosis? The scoliosis affects between 3% to 30% of the population, and about 0.25% require the treatment. And the incidence of the scoliosis increases with age. The more you grow up, the more you have the tendency to develop the scoliosis in adolescent children. We'll see it later in idiopathic sclerosis. The prevalence of sclerosis is 1% to 2% in school children and rises above to 8% in adults aged 25 and older. What are the classifications of scoliosis? We classify scoliosis depending on the cause, the age of onset or when it started, the severity of the scoliosis, and the last type of curve of that scoliosis. So let's start with the scoliosis classification according to the causes or the etiology. The first one might be a neuromuscular sclerosis. The second one is congenital sclerosis, where the child or the baby is born with some segments which are not separated, or the vertebra are not separated, or there is something which is missing. We will see it later. And the last one is idiopathic scoliosis, where the cause is unknown. With neuromuscular sclerosis, the lateral curvature comes from the poor muscle control, or the paralysis, or sometimes weakness of the muscles of one side, and also sometimes the neurological problems associated with underlying conditions including cerebral palsy, spinal bifida, poliomyelitis, or spinal cord injury. So in this case, you find that these weak muscles, and here they are strong muscles, so they may tend to develop the curvature and tends to develop the scoliosis. In this neuromuscular, it's second form of scoliosis after the idiopathic scoliosis. With this, it tends to progress and after skeletal maturity and even in adulthood. Whereas in idiopathic scoliosis, after the skeletal maturity, there is no curve progression. How about the congenital scoliosis? As from the word congenital, it's something you are born with or present at birth. So it's an abnormal development of the spinal vertebra with the vertebral anomaly being present at birth. When we look at this picture, we can see this vertebra wasn't formed fully. It's half of it, which is there, so it developed the scoliosis. And other conditions, some vertebrae, they are not segmented well, like on this side. And on the last side, we can see that the vertebral bodies are not segmented as they're supposed to be. So all these are congenital anomalies which lead to congenital scoliosis. So it is characterized by longitudinal and rotational imbalance in the spine. Let's see what is idiopathic scoliosis. From its name, idiopathic means it's a known cause, and it's the most common form of scoliosis with a prevalence rate of 0.47 up to 5.2% in general population. And idiopathic scoliosis is classified in three types, where it relates to the age at which it is first noticed. The first classification of idiopathic scoliosis is infantile scoliosis, where it is present under the age of 3. The second type is juvenile scoliosis, where it's diagnosed between the age of 3 to 9. And the last one is adolescent scoliosis, where it's diagnosed between the age of 10 to 18 or skeletal maturity. From the symptoms and physical findings of the idiopathic scoliosis, we see most of the time that the patient doesn't have any pain or they don't feel pain. And there is a visibility of the hunched rib cage and the lumbar bulge that it is causing. We see also the asymmetry of the shoulders. From this picture, you can see there is uneven shoulder levels. We can see also the curvature in the spine, and the pelvis are unlevered. So these most of their symptoms and signs of an idiopathic scoliosis. So with infantile idiopathic scoliosis, this is a non-congenital scoliosis. So don't confuse it with a congenital. So at birth, the patient is not having a scoliosis, but after some months or first year, the patient or the baby presents a scoliosis. So that's idiopathic scoliosis. And the infantile scoliosis resolves spontaneously in more than 80% of cases requiring no treatment. So for this infantile scoliosis, most of the time they resolve themselves, they don't require any treatment. And the rest, only 20, are the ones to be treated. So with Meta, he has what we call the rib vertebral angle difference, which was developed in order to know which one will resolve immediately, which will not require any treatment, and others which will progress rapidly. So he said that the angle difference of 20 indicates a poor prognosis and rapid progression. Let's see how he did it. So we are having, if there is a difference or it's more than 20 degrees, there will be a rapid progression of the curve. But if there is less than 20 degrees, it means it will resolve itself. So the child or the baby will not require any treatment. So we can see how we measure it. From the apical vertebra, we will see understand what is an apical vertebra. You identify it, and then you have to locate also the ribs from that apical vertebra. You can measure a line in the center of it and another line on the other side, and they have to, you bisect from the end plate of that apical vertebra. You make a perpendicular angle of 90 degrees. You have to have this line up to the vertical perpendicular line. You measure this angle, and you take another angulation from the left or the right rib depending on the curvature, and you can measure the difference. If you see the difference of these degrees is more than 20, it means there is going to have a rapid progression of the scoliosis, and it requires a treatment as soon as possible. For juvenile idiopathic sclerosis, as I said, this is a non-congenital sclerosis also, where the patient is diagnosed between 3 and 9 years old. And most of the time, males are more affected than females with a right thoracic curvature. And when it's not treated, it may cause serious cardiopulmonary complications where the patient may not be able to breathe or have some problems with the heart. And the curve of more than 30 degrees tend to progress up to 95%, may need a surgical procedure. So if these surgical procedures are not done and the patient develops these cardiopulmonary complications, they may end having death at a later stage. How about the adolescent idiopathic sclerosis? In this idiopathic sclerosis, the adolescent scoliosis is in patients where they are diagnosed between the age of 10 to 18 years old. And approximately 1 to 4% of adolescent population is affected by this condition, and females are more affected, which is different from the juvenile idiopathic sclerosis where males are more affected. And there is this likelihood of progression among adolescents with Cobb angle less than or equal to 20, and it's ranges from 10% to 20%. And there are some risk factors which lead to adolescent idiopathic sclerosis, where if the child is having the age between 10 to 18, they are prone to have this scoliosis. And also the genetic factors. For example, if you have a family member or your older sister is having scoliosis, you may develop it also. You may have it, so it's better you go for screening because the genetic factors are also included. And the third one, where the females are more affected than males. Let's see the types of sclerotic curvature. There are different types of sclerotic curvature. The first one is structure or non-structure. Non-structure, most of the time, is called functional. If they use functional or non-structure, it's the same. Don't get confused. So the structure curvature is when the curve of the spine remains once the patient bends on the side. So for example, you assess the patient, he bends, and when he reaches on the lateral side, and that curvature is remaining, it doesn't correct itself, it means that a structure curvature. But if it reduces, it means that's a non-structure curvature or a functional structure curvature. And other types of the sclerotic curvature, they may depend on primary and compensatory curvatures. When do we call it a primary curvature? A primary curvature is the curvature which comes before the other. For example, if you have two curvatures, for example, you have thoracic curvature and lumbar curvature. So the one which appears before the other, that's what we call the primary curvature. And when it comes the second, we call it compensatory curvature. And compensatory curvature, most of the time, it's less than the primary curvature. How about single, double, and double major curvatures? How do we differentiate them? In case you find a patient is having only one-sided spinal deviation, we call it the single curvature. This is an example from this picture. So from this picture, you can see on the X-ray we are having only one curvature. So it's a thoracolumbar curvature on the left side. How about the two-sided or double curvature? It's when from the film you can see there are two spinal deviations. From the lumbar region and the thoracic region, you can see there is a left lumbar curvature, and on the right thoracic curvature, we call them the double spinal curvature. You don't need to have the same magnitude. This looks more angulated than the thoracic curvature. How about the double curvature, double major curvature? In this situation, the magnitude are almost the same. Let's look at the picture. You can see from this, they are almost the same angulation. They have less than 5 degrees of difference. We call them double major curvature or scoliotic curvature. So let's look at scoliotic curve patterns. In scoliotic curve patterns, we have the cervical curve patterns, where we have the apical vertebra from C1 to C6. But before we talk about apical vertebra, why do we understand? Let's use this picture first. If you want to define what is an apical vertebra, most of the time the apical vertebra is the vertebra which is least tilted and most displaced from the midline. Okay, so we can estimate that this is our apical vertebra, and it is the most rotated. If the patient bends, you can see the one which is having a hump, and you can feel that's more rotated. That's the apical vertebra. So from this, when you have a scoliotic curve pattern in the cervical region, the apical vertebra has to fall between C1 and C6. When is it called cervicothoracic curve pattern? It's when the apical vertebra, or the apex is the same name, it's when the apical vertebra is between the C7 and the T1. And when do we call it a thoracic curvature? It's when the apical vertebra is between the T2 and the T11. How about the thoracolumbar curvature? It's when the apical vertebra is between the T12 and the lumbar 1. And the lumbar curve pattern is when the apical vertebra is between lumbar 2 and the lumbar 4. And the last one is lumbosacral curve pattern, is when the apical vertebra is located between L5 and S1. So how do we assess the patient with idiopathic scoliosis? The first, we have to start with subjective assessment, where we have the patient history. We need to ask the patient the age at first they recognized their problem or their deformity, because we studied that we're having 3 types of idiopathic sclerosis depending on the age of onset. So this will help us to know whether it's infantile, whether it's juvenile or adolescent. And we need to ask also the different symptoms. Maybe the patient may have pain, or they feel fatigue, and sometimes they have cardiopulmonary symptoms. If they have these cardiopulmonary symptoms, the problem with the heart and the lungs, it means maybe it's worse. So we need to treat the patient as soon as possible. The family history, it's really important, because if one of your family members is having sclerosis, you need to know it, to know the genetic problems. Maybe you need to bring your young sister so that they can be assessed. After you've corrected the patient history, we have to do the physical examinations. In a physical examinations, most of the time, Adams forward bending test is very important. Let's see what is Adams forward bending in the following slide. But you have to have also radiologies to confirm everything that you are suspecting. So in radiology, we can use the Cobb angle. So we'll see how we measure the Cobb angle later. But this Cobb angle, it shows us the degrees or the magnitude of the curvature of the spine. So we measure it in angles. And we have to know the skeletal maturity. Skeletal maturity, it shows how the patient has grown. If they are still young, the skeletal maturity, they are still immature. But the more you grow up to 18, we can reach the skeletal maturity where we have to see if the bones are fused from the ear crest, and we can know what is Risa sign 1, 2, 3 to 4. So those help us to know if the patient is going to reach the skeletal maturity. Most of the time it's 18 years of age. And we have to know also the vertebral rotation. As I said, the scoliosis is 3-dimensional, so we have to know in transverse plane whether it's having more rotated. So the more rotation, the more complicated is the treatment. So in physical examination, we have to inspect first. We have to see the shoulder symmetry. Are the shoulders leveled or one is lower than the other? We have to see the scapular prominence. Is one more prominent than the other? We have to check the pelvis. Is it leveled or one side is higher than the other? And we have to see the gap. When the patient is standing still, we have to see if the gaps are equal. If they are not equal, it means we are suspecting there might be a spinal curvature which leads to the scoliosis. As I promised you, we need to understand what is Adams forward bending test. So the Adams forward bending test is a test with a purpose to determine whether it's a structural or functional scoliosis. Remember that we talked about the structure scoliosis and non-structure scoliosis, where the patient bends on the right side. If it doesn't reduce, it means it's a structure. If it reduces, it means a function. It may be caused by many problems which are not from the spine. Maybe a patient is having unleveled leg length, or the pelvis is having a problem and they are not leveled, so it may tend to create a curvature in the coronal plane. So what do? We ask the patient to stand and bend forward at the waist, with us examiners to assess the symmetry of the back from the behind and on the beside of the patient. And the scoliosis will have a lateral bending of the spine, but the curve will cause the spinal rotation, and we can feel the rib hump when the patient is bending in the examination room. So in radiology, as I said, this is the most important diagnosis that we have to use, where we have to confirm exactly whether the patient is having the scoliosis or not. We use the Cobb angle to measure the magnitude of the angulation or degrees of the spinal curvature. So we have to take a radiograph in the coronal plane or frontal plane, and then we can see, for example, in this picture, we can see there is a lateral curvature. So from this lateral curvature, we can be able to measure the angulation. So how do we measure the angulation? We use most of the time the Cobb angle. This is a gold standard and it has been proved in many researches. So how do we do it? First, we have to identify the apical vertebra. I explained later, before that, apical vertebra, it's a most displaced vertebra and less tilted. And once we we identified it, we have to identify the upper and lower vertebrae, where these are most tilted vertebrae of the calf, and we have to make straight lines on the superior border. In patient assessment, we have to do the radiography. This helps us to confirm if the patient is having the suspected scoliosis and how much we can identify as the curve angle. So we'll be able to measure if it's 20 degrees, 35, like for example from this picture. So how do we measure this curve angle from the radiography that we took? First, we have to identify the apical vertebra. And as I said, apical vertebra is the most displaced vertebra from the midline, and it's less tilted. And this is the most rotated vertebra of the curve pattern. So after identifying it, we have to identify both lower and upper vertebrae of the curvature. So these are most tilted on the proximal, and the distal we have to identify the lower end vertebra, which is most tilted. And we have to take these, we have to draw the straight lines which are parallel to the superior end plate of upper vertebra, and the inferior upper vertebra we have to draw the line which is parallel to the inferior end plate of the lower vertebra. And then once we measure, we've drawn those lines, we have to cross them. We have to cross them, and we can be able to identify what is the magnitude or what is the angulation of the spinal curvature that we have. So that's the curve angle or method of measuring the spinal curvature. There are other methods that are used, but this one is the gold standard. We have also to measure the skeletal maturity. We need to identify if the patient has already grown enough or there's still maturity. We can know from the age of the patient. Most of the time, if the patient is like 12, 10, they are still immature, but when the patient reaches to 18, they reach to skeletal maturity, and the RISA sign is at level 4. So most of the time you can check from the iliac crest. If it is fused fully, we call it RISA sign 4 to 5, but if it's still not, we can have RISA sign 1 or 2. And that time the patient is not mature yet. So this helps us to estimate the degree of rotation of the vertebra at the apex of the curvature, looking to the relation of pedicles to the midlines. And the vertebral rotation, we have to check it using a scoliometer. We'll see what is a scoliometer in the following slides. So in the treatment of idiopathic scoliosis, there are conservative treatment and non-conservative treatment, but before we look at the conservative treatment and non-conservative treatment, there are some baselines that we have. There are factors that we have to base on. As I said, the skeletal maturity. The patient is already mature or not. They are still young, 8 years old, 9, 10. The magnitude of deformity, we have to use the curve angle. We know if the patient is less than 45 degrees, maybe 20 degrees, so we have to identify that magnitude of the deformity. And we have to see if the patient is having a curve progression tendency. Because if the patient is having like 35 degrees and they are very young, they haven't yet reached the skeletal maturity, especially, for example, in juvenile scoliosis. If they have 35, they have tendency to have the curve progression. As I said, we have conservative and non-conservative treatment. Conservative treatment, this is a non-surgical or non-invasive treatment where there is no surgical operation required. and non-conservative, it's about surgery. And less than 45 degrees curve angle is best for conservative treatment, and if it's more than 45 degrees, they recommend non-conservative treatment or the surgery to correct the spine. So with the conservative treatment, there are many ways we have to use. The first one is early detection through screening. In screening, maybe we go to the school, we find children, we can assess if they are having scoliosis or not. They may not know what is it, but through the screening, it can be the first step of detecting the scoliosis. And early detection will lead to better outcome. The second, they can use physiotherapy. The physiotherapy, we have this exercise called Physiotherapytic Sclerosis Specific Exercises, PSSE, for mild curves which are less than 25 degrees curve angle. This is where the researchers they suggest. And we can use bracing, or we use the spinal orthosis for the moderate curves. So depending on the severity. The moderate means from 25 to 45 degrees, and mild means less than 25 degrees. For bracing, we can use within this range. And in case there is non-conservative treatment, it's when there is 45 curve angle is required. So if the patient is having severe curve, which means more than 45 degrees of curve angle, the surgical operation is the only solution when the patient hasn't reached the fully maturity of the skeleton. So today we are focusing on conservative treatment, as the topic said. Let's start with the first one, early detection through the screening. This is very necessary because it helps to prevent the progression of the curvature and even to severe sclerosis. As I said, severe sclerosis requires surgery, so we are preventing further requirements of surgery, which is invasive and may cause some other problems. Our scoliometer is a very important tool which helps in screening. This is a tool which is used to place directly on the rib to determine the degree of rotation. First, you have to locate the apical vertebra, and we have to check to position it on the level of the apical vertebra and on these ribs. So there is a scale in degrees that helps us to measure the rotation. So the patient has to bend forward and reposition the scoliometer, and you can be able to detect what are the degrees of the scoliometer. And there is a way we convert this rotation where 5 degrees equals to the 11 degrees in curve angle, but 7 degrees of this angle trunk rotation is referring to 20 degrees. But these are subjective. They have to confirm with the curve angle later. So this is the first way of treating the idiopathic scoliosis, by observation and early detection through screening at schools and at home. So the second treatment is with physiotherapeutic scoliosis specific exercises. And this PSSE is a program containing individualized specific exercises to treat the curvature, the magnitude, and clinical characteristics of that scoliosis. So patients are provided with specific exercises that are rated to the individualized, or they are specific curvature they have, because one may have a single thoracic curve, another one may have double thoracolumbar, thoracic and lumbar scoliosis, and with different magnitude. So each patient has individualized exercises. The aim of this program is to reduce the deformity and curve progression. The second one is to limit the need of bracing or surgery, because most of the people, they don't like the bracing because of the cosmetic appearance, so they require these physiotherapy exercises, and this is the second aim of the physiotherapeutic scoliosis specific exercises. People have developed different approaches in physiotherapeutic scoliosis specific exercises. The first one is the scientific exercise approach to scoliosis, known as CEAS. The second one is Scroth method, which was developed. The third one is Barcelona Scoliosis Physical Therapy School. Another one is the Functional Individual Therapy for Sclerosis. These are among many physiotherapeutic sclerosis specific exercises I've introduced to you. If you need more, you can search for more, but these are selected for you so that you can know them, because there are many. So let's see one by one. The SEAS, this first you have to help the patient to understand or to be aware of their deformity and promote the self-correction, because this is about self-correction exercises. And you have to activate the stabilization, including intensive symmetry activation of all stabilizing muscles. So the patient has to have the exercises which activate the stabilizing muscles, and there is a balanced stimulation exercises, and also the patient has to be given the home program. When they reach at home, they have to do some physical exercises which are easy for them, but they have to be prescribed from the physiotherapist or a doctor. And the second one is Scroth method, where first you have to help the patient to improve the awareness to their deformity, to promote self-correction. Repeated 3D asymmetrical spinal correction exercises, because we said scoliosis is three-dimensional deformity. So these exercises, they have to combine all three planes. So these include the pelvic alignment. So they help the patient to align the pelvis, the shoulder correction, so that they are unlevered. Elongation, so stretching, because the curvature is a little bit complex, so we have to elongate from this exercise, and the other exercise are side shift thoracic exercises. Other exercises given to the patient are corrective breathing. So the patient are given specific exercises. When they are breathing, they are trying to correct the scoliosis they are having. And another is integration of postural correction within activities of daily living. When they are doing their normal works at home, they are given some postures or normal postures that they have to use so that they can correct. If, for example, in sitting, they have to sit in the right sitting so that they don't bend their spine, or on the lateral side. So there are many exercises that are given to them. And as well, there are some easy and safe home exercises they are provided from this program. So the third one is PTS that we saw in full words in the previous slides. So it follows the Scroth method. It's a 3D autocorrection with external assistance during the training. So in this, the patient corrects themselves, but they need an assistance from the trainer when they are studying how they can perform this autocorrection of this spinal deformity. And there's isometric muscles tension, they are needed to stabilize the position. And even breathing mechanisms, they are given to the patient, where they are going to shape their trunk using those breathing exercise or mechanism they have to use in their daily activities. FITS, same as the two first physiotherapeutic scoliosis specific exercises. First, the patient has to be aware about their deformity and promote the self-correction. You have to do the relaxation of myofascial structures of responsible in imitation to the correction of forces. 3D correction movement using elastic resistance. So they use elastic materials which helps to correct in all planes the scoliosis. The breathing exercises which help in correcting the spinal curvature. And this most of the time is mixed with the bracing. So if the patient is having a brace, you can still provide the fit as well as the Scroth method. That also there is, when the patient is using a spinal orthosis, you can provide the Scroth method, you combine them, which provide better outcome. So we finished with the physiotherapy. Let's focus on the braces. As we said, the braces are provided for the patient who have moderate scoliosis. So the moderate scoliosis is between 25 to 45 degrees of the curb angle in the curvature of the spine. The goals of the spine or spinal brace, most of the time people call it orthosis or braces, depending on what you know more. So this first and the most important goal with the spinal brace is to prevent the curve progression. So with this spinal brace, it doesn't reduce the curvature, but it prevents the curve progression. If, for example, a patient is having 25 degrees when he's like 12 years old, we want to keep 25 degrees up to 18 degrees. And after 18 degrees, as idiopathic scoliosis is, it doesn't progress after skeletal maturity. So we try to keep as much as possible the prevention of the curve progression. The second one is improved structure alignment. If the patient is using a brace, the patient is no longer bending on the side. We have to realign the trunk. This is another goal. The third one is the appearance of a patient. This brace improves the appearance of the patient. It improves also the trunk stability because some muscles are weak and others are strengthened. So this imbalance is improved and the stability is achieved. In cases where there is pain, with the spinal brace, you can reduce pain as a goal of this. And also, in some cases, there is an angulation, reduction, or rotation as a bonus. It's not always that the patient will achieve the correction or the reduction in angulation, because most of the time it doesn't reduce. If it happens, that's a bonus. And when the patient is having a severe scoliosis, they tend to have this cardiopulmonary function. So cardiopulmonary problems. In this case, we provide the spinal braces to improve the function and the patient may reduce the pain. So with the spinal orthosis, is selected referring to the apical vertebra of the scoliosis or the scoliotic curve. Remember we talked about what is apical vertebra. It's very important in spinal braces. So in case the apical vertebra is on T8 or above, in this situation, we prescribe a Milwaukee brace, or most of the time it's called cervicocolumbar sacral orthosis, or CTLSO is recommended. And if the scoliosis is having an apical vertebra which is below T8 or T8 and below, we can provide a low profile orthosis, also known as a TLSO or thoracolumbar sacral orthosis. Starting with the Milwaukee brace, also known as CTLSO. This from this picture, it's an extended up to the cervical area. As I said, CTLSO. And this was introduced in 1946 by Schmid and Brandt. And this orthosis offers a longitudinal destruction with a lateral pad for curve correction. So if you see this curve correction pad, it means the patient is having a convex side on this side. So it's correcting. And it looks uncosmetic and bulky to the patient because of these metals which are extended up to the cervical area. The second one is a Boston brace. This Boston brace is below the cervical region. So it's not a CTLSO, it's a thoracolumbar-sacral orthosis. This was introduced in 1972 by Hall. It's a low profile because it doesn't exceed the thoracic area to above. When it was introduced, it was a prefabricated thoracolumbar-sacral orthosis, custom fitted for patients with different sizes and curvature patterns. So the patient couldn't come and they cast or they take measurements. It's just they are prefabricated there, and the patient comes and fits depending on the size, their sizes and curve patterns. If they are thoracolumbar, if they are thoracic or lumbar, they have to fit according to the curve pattern they have, and also the magnetic. The third one is the rigid Rigaud-Chenot brace. This was a customer made, so different from the Boston brace. For Boston brace, it was fitted, prefabricated at first, and this one is a hand casted from the patient. The patient comes, they have to cast them, and this has an overcorrection. The overcorrection to the side which is non-affected. So this hypercorrection, it's done on the positive model, and the build-up to allow the patient to move and breathe, as well as to grow towards the opening space. So this opening space on this side, they provide the room for growth, and towards the side that we want the patient to realign the spine. So where it is different from the Boston is almost symmetric and it doesn't have hypercorrection in it, and this has many holes compared to the Boston brace. And this, from its biomechanics, it has to be hand casted. There is a Charleston bending brace also in the spinal braces that we provide. This Charleston bending brace, it was introduced by Reed and Hooper in 1979. As you can see, it's bending to the side, so it's overcorrection. So if the patient is having a scoliosis towards this side, you have to overcorrect to the maximum on the other side, which is normal, so that you can correct the curvature. And this is because it's having the maximum curvature and the patient can't walk with this hypercorrection. It is used during the time of bed or at sleep. They only use them during night. And other types of the braces that I mentioned earlier, they're used both during day and night. So they use them 23 hours or 16 hours. The Charleston bending brace was introduced by Reed and Hooper in 1979. As you can see from this picture, it's overcorrecting. If the patient is having the curvature toward this side, there is maximum correction to the side which is convex, so that you can correct the curvature. And because of this maximum correction, the patient uses them only at night or when they are sleeping. While other braces that I have mentioned earlier, they use them both during the day and night. So they can use them 23 hours a day in early stages of treatment, and they remove them only when they want to take a shower. So it is indicated for a single thoracolumbar curvature or lumbar curvature between the age of 12-14 years of age, and for this flexible curvature in range of 25 to 35 Cobb angle. As you can see from this picture, it's only provided for single curvature. For example, if it's a single lumbar curvature, but if there are double curvatures, this orthosis is not appropriate. You have to go for other types of braces, and they have to be flexible. If the curvature is rigid, you don't provide the Charleston bending brace because we need to overcorrect. If you overcorrect something which is rigid, you are causing problems to the patient and they can't correct it. Thank you very much for your attention. These are the references. If you need to read more of this, you can go and check from these references I'm giving you.